All right, welcome back everyone to another virtual shadowing session at Hearts for Health. It has been a while. This is our first summer session in 2023. It's been almost a month since we've had our a shadowing session in general. So we're happy to have you all join in, and we're very excited for today's session. It's going to be about pediatric gastroenterology. We're joined by Dr. Shweta. She's a pediatric gastroenterologist at Stanford. She's going to be talking about careers in intestinal failure today. And I do have some reminders before we do dive into that topic, especially for those of you who are new. I know with each semester, when we start each semester, there are a couple people who hear about our programs who are new. So this is mainly for y'all. If you've already been on one of these shadowing sessions before, you probably have heard this, but it's just going to be quick. So a couple reminders in terms of our structure. At the very end of each of these sessions, if you're not familiar, we do have a Q&A. If you have any questions for Dr. Shweta, feel free to type them in the chat. That chat is either on the right-hand side or just below the live stream that you're viewing right here. And we will cover those in the order that we receive them at the very end of today's session. Also, we do have just more than this session. We have quite a few sessions that we've been hosting over the past years. And we host those sessions mainly on Mondays and Thursdays. This one is going to be our first one of the summer semester, and we're going to be expecting to have more coming on Mondays and Thursdays, like I said, at 7 p.m. Central. That's our starting time. There might be some variance with that. And to be in the loop over that, we have two great ways where you can check in on when sessions are going to be and what speakers we have. We have our listserv, which is just an email listserv sent out weekly, again, with our speakers, our flyers for each speaker. And then we have our Instagram page, which also we have our flyers on. We post flyers there. The only difference I'd say between the two is that on our listserv, we do have a couple more opportunities that we share. We have more than just a virtual shadowing program. We have a couple volunteering programs. We also have a mentorship program. So if you happen to be interested in those, I'd recommend you sign up for our listserv. And that really is all. I do want to drop our email. If y'all have any questions outside of what I just mentioned, it's the address is community@hearts4health.org. And you can reach us out for any questions that you might have about shadowing, about our volunteering programs, about mentorship, anything. We'll be sure to answer them. But that is all for reminders. Like I said, if you have any questions outside of what I just mentioned, feel free to email us. I don't want to take up too much time, though. So Dr. Shweta, feel free to take it away.
Thanks so much, Michael. And thanks again for the invitation to chat about careers in intestinal failure. I am super excited to talk to all of you about this. This is a really incredible field. Obviously, I'm really biased, but I think there's incredible opportunities to help people facing significant inequity from many, many pre-health fields, including pharmacy, nutrition, surgery, and medicine, maybe even radiology. So I think this field is really multidisciplinary, and that's why I love it. And I hope that you guys will all learn a little bit. We're going to start off with the pre-quiz. So just keep these questions in the back of your mind, keep your ears open for the answers throughout the talk. So I want you guys to try to see if you can hear and identify the three major causes of intestinal failure. If somebody has short bowel syndrome, can the bowel grow back? And if so, what is the name of the treatment that's required for rehabilitation? And then just two numbers that I want you guys to try to hone your ears in on. I want you to ask yourselves if you can identify what percentage of people with short bowel syndrome adapt or achieve independence from TPN, and then try to hear if you see what is the 30-year survival for people living with chronic intestinal failure now and when care for people living with this condition started. And that's sort of assuming appropriate, accessible, and equitable care. Okay. So I thought we would start off with three cases, and we don't necessarily have to go through a huge discussion, but I want to just briefly go through them and we can talk more about the cases towards the end. So the first case is a 37-year-old woman with very high volume amniotic fluid. And so this woman during her pregnancy required amniotic fluid taps up to 10 times during her pregnancy. And every time she was tapped, she got almost 600 to 1200 mLs of fluid out per tap. So this is one case. Another case is that of a 4-year-old X29 weeker from Louisiana, whose parents report 3.5 years of non-bloody diarrhea. You can see from the photograph that he has very significant physical exam findings And his family is really devastated because they've been doing everything that they can. Mom reports that he eats more than any of his siblings, and yet he remains very thin, developmentally delayed to about a year and a half old. He seems tired. He can't play with his family. He can't keep his head up. He can't go to school because the diarrhea is so severe. When you examine him, you notice a few things. So one, he has fine muscle wasting, temporal wasting here on the head, a rather large head with thin hair. He is sort of tired and his face is sort of downtrodden. You can see all his ribs, and he has large muscle wasting as well. You can see all of his joints are bigger than the space in between the joints. And this is both in the upper and lower extremities. And if you look at his feet, they look sort of puffy. That's a sign that he has edema there. And his abdomen has a scar across it, and it's quite protuberant with a lot of fluid shift. You're a little puzzled as to what could be causing these symptoms. So you order some labs and you see that he has a low albumin, a borderline thyroid stimulating hormone, a borderline ALT, CRP, and anemia, and a very low ALK phos. So this alkaline phosphatase level would be normal for an adult, but is absolutely not normal for a child. And he's got a borderline calprotectin as well. And then the last case is that of an 8-year-old girl who was admitted to a local children's hospital. And you look through her chart and you see that she's had over 16 admissions in the past 8 years, all for episodes of prominent, painful abdominal distension. And some of them seem to be triggered by routine upper respiratory infections. Most of her admissions were during the summer, and her family reports that sometimes they feel like dehydration may trigger these episodes of abdominal distension. Her family is frequently told during these admissions that their daughter is fine, that there's nothing wrong with her, and that she needs psychiatric therapy, especially because she seeks pain medications only during these episodes of pain. She's not using pain medications when she's at school or at home. Of note, when you ask a family history, many members in her family have a history of chronic constipation, as well as chronic kidney disease. In fact, one family member required a renal transplant for neurogenic bladder. So these are 3 very diverse cases, and I want you to try to think behind all 3 of these cases, what could be causing these symptoms? The common theme behind all of these cases is that all 3 of these children, and I include in the adult case of the woman who was pregnant, the infant that was ultimately causing the high volume amniotic fluid. All 3 of these children had what we call intestinal failure. So we define intestinal failure as the inability to use the intestine for fluids, electrolytes, nutrition, and I would argue growth and development for children, as well as adult functional status. Can you walk upstairs? Can you climb? Can you attend work? Can you pay attention in school? Things like that. We say that if you can't use your own intestine for a period of 2 to 3 months, then that is the definition of intestinal failure. Now, I think many of you have probably heard of heart failure and kidney failure and liver failure, but sometimes when I talk about intestinal failure, folks are a little puzzled. And that's really hard for me because I see children and adults who absolutely deserve equitable access to the top-notch care, right? And what's hard for me, especially as a specialist in this field, is that the treatments that are available for this have been around now 60 plus years. So it is true that prior to 1967, intestinal failure was usually fatal. So for example, if you're unfortunate enough to end up in a motor vehicle accident prior to the late 60s and lose a large piece of your bowel, you could pass from dehydration and malnutrition, and people usually would succumb to that in the hospital. But by 2004, we have good data that showed that with this treatment for intestinal failure that was invented in the 60s, people were thriving. 80% of people could come off this treatment, 90% survived. It just requires access to expert care and people who really care about this problem. So I think the first step is you have to have heard about this problem. The second step is you had to have had some type of training in the care of this problem. And to me, this is a disability, economic, and racial justice issue. Globally and in the United States, without this equitable access, people suffer tremendously, and it actually still can be fatal. So what is this treatment? So the mainstay of care for folks with intestinal failure is parenteral nutrition. This is a bag of IV fluids that you can see hung here by Stanley Dudrick, who, by the way, invented TPN when he was a surgical trainee during his research fellowship years. This is a bag of specialized sterile IV fluids that contains all your macros, so protein, carbs, and fat. It contains all your vitamins, and it contains all the electrolytes you need: sodium, potassium, magnesium, acetate, or bicarb to help with your acid-base balance, copper, zinc, and selenium. And so it's really basically all of the nutrition that you could need put into a bag and compounded by expert pharmacists nowadays. I'll let you know what we used to do way back in the day. And really, this treatment can take somebody who is very, very malnourished. Here you can see an infant. This was one of the first infants that Dr. Dudrick had treated. And these photographs are from his obituary in the New York Times. You can see this baby, like the 4-year-old, has similar features, right? Sort of this malnutrition, apathy, or irritability, large muscle wasting. This baby doesn't quite have edema. This baby looks more dry and malnourished, but with the advent of this treatment, could really thrive and be quite normal. So this treatment has existed for people living with intestinal failure since 1967. In the first 10 years after this medication was invented, the first pediatric patient went home on home parenteral nutrition, meaning they were able to leave the hospital and administer this specialized bag of IV fluids in their home in 1977. By 1987, 100 patients or so had gone home already, and half of those 102 patients had basically already come off TPN by the time this study was published. What I find really fascinating is just in the first 10 years after this supportive nutrition was sterilized, compounded, invented, and innovations were made to help administer this nutrition through a catheter, 100 out of 102 of people living with intestinal failure in 1987 went to school. And these are pediatric patients. The next 50 years really focused on, number one, can we prevent intestinal failure? Can we use car seats so kids are not getting in motor vehicle accidents? Can we identify volvulus ahead of time, get a sump in a kid so that they don't twist and have bowel necrosis? Can we prevent necrotizing enterocolitis and improve prematurity care? Can we prevent prematurity in the first place? So really, that was our goal from 1968 to 2018 were these 4 goals: preventing intestinal failure, preventing mortality from intestinal failure, using that bag of nutrition to optimize growth, development, and the physical exam, and then avoid the complications that can come from the treatment itself. And that's kind of what we did for 50 years. Does anybody know why I have a photograph of a garage here? I would like you guys to put a pin in that, and we could talk about why I have a garage in this slide towards the end of the talk. So what do people living with intestinal failure have to say about the treatments that have been available? So in the disability justice world, people say nothing for us without us. And the community-led research is just being published. There's an amazing group called the Oli Foundation, another really amazing group called the Gutsy Perspective, and many of the members of those groups published this paper in the Journal of Pediatric Surgery in 2022. And you could see here, this is what folks, either caregivers or people living with intestinal failure and short bowel syndrome, had to say about child well-being and about quality of life. I think what's sort of interesting here is that while maybe 20% of people said that their quality of life for their child today compared to what they were told to expect at the time of intestinal failure diagnosis might be a bit lower, a large portion of people, 35.7% respectively, said it was either a bit higher or much higher than they were told to expect by their medical team. So now we've got 50 to 60 years under our belt. We've got community-led research. People should be fine, right? So 60 years later, I will tell you there are still huge opportunities to improve equitable, just expert care for people living with chronic intestinal failure. 60 years later, you could see here in a study that was published by Mundi and other folks in the Journal of Parenteral and Enteral Nutrition, that people are traveling extraordinary distances to receive appropriate care. So, and you could see here on the x-axis that there's distance in miles, and then the percentage of patients in this study that this was pooled Medicare data looking at diagnostic criteria that are a little bit tricky, as we'll talk about at the end of the presentation. Intestinal failure is an umbrella term, and even though the requirements to achieve that diagnosis are the same, there are many, many diverse diagnoses that lead to this. So for that reason, people are traveling, like there's a peak here for pediatric patients around 100 miles. And I would say most of the people that see me are traveling somewhere around 100 to 300 miles. You could see that there is some geographic variation in that folks on the West Coast are traveling up to 1,000 miles. There's a peak here compared to folks in the Northeast that are able to get care in this sort of 10 to 50 mile range. But this really shouldn't be the case, right? This doesn't really seem fair, and this personally makes me mad. So why is this happening, right? Why are people with intestinal failure experiencing significant suffering, and why don't they have access to high quality care? And in these photos, these are photographs of enterocutaneous fistulas, and I cannot tell you how many people I've taken care of who were told they had to just sort of live with these tubes and lines and open wounds for decades of their life. Now, enterocutaneous fistula is one of the more rare causes of intestinal failure. The most common cause is short bowel syndrome, where the intestines are cut short for some reason, usually necrotizing enterocolitis, motor vehicle accident, gunshot wound, or something like a volvulus, which is a twist in the intestines. Congenital enteropathy is the next most common cause, and that's what the cause of that patient that was experiencing the high volume amniotic fluid was. That's a congenital salt wasting diarrhea, for example, or intestinal pseudo-obstruction. But folks with fistulas make up the fourth group, and I can't tell you how many people are told to just go home, feed by their tube, when they really can't sustain, again, their growth, electrolytes, nutrition, and activities of daily living. So why does this happen, right? This makes me mad. This should make everyone mad. This is not acceptable. It is 2023. We have had 60 years of appropriate treatment. We have had multidisciplinary teams, pharmacists, nurses, dietitians, surgeons, and physicians who subspecialize in this all across the country and all across the world. Why is it that people are traveling 1,000 miles to seek care? And I don't think it's because anyone intends on doing harm. I don't think that in the healthcare field, whether you're a pharmacist or nurse, a dietitian, a physician, or a surgeon, that you intentionally neglect your patients. But I think what can happen, because intestinal failure is a multi-organ illness, and I really encourage anyone who's interested in learning about the comorbidities associated with intestinal failure to read this article in the New England Journal by Chris Dugan's group. Multi-organ illnesses don't always fall into one box, right? It's not just the radiologist's issue to deal with the central line. It's just not the hepatologist's issue to deal with the liver. It's not a dietitian's job to just deal with the formula. It's not the gastroenterologist's job to just deal with the bowel inflammation or fistulas or volvulus that can occur, the bowel dilation, these complications. It's not just the surgeon's job. So there's a gap, right? And unless you really have this multidisciplinary team where folks meet every week, chat together, get to know each other, take care of patients together. And by folks, I mean what NASPGHAN, or the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and pancreas is in there somewhere as well, defines as a multidisciplinary intestinal rehab team. This includes a surgeon, a dietitian, a pharmacist, a physician, and a nurse. And that's hard to do, right? Hospital systems, insurance companies, they don't get paid for that type of collaborative team-based care. And so I think this is why multi-organ illnesses are neglected. And I think this is why there are gaps and opportunities in the care of people living with intestinal failure. So what do I hope for in 2020 and beyond? I hope that there's more multi-center prospective research moving beyond just single center experiences. I hope we can have innovation in medical devices. And for anyone who has sort of a bioengineering mind, I encourage you to read James Dunn's work on distraction enterogenesis, and I'd be happy to answer questions about what that is and what that could look like. I think we need policy change, right? We don't just tell people with heart failure to go home and pray that their diuretics work, right? We have subspecialist care, we have primary care, everyone is educated and informed and works together and takes care of folks with heart failure. Why should it be any different for intestinal failure just because it's complex? We need more trainees in the field. We need more pharmacists who are dedicated to this, surgeons and physicians and nurses who are really nurse specialists in the care and management of central venous access, and really who are intestinal failure nurse specialists. There is an amazing opportunity. If you guys have a chance to Google Lift Echo, if you want to learn more about intestinal failure, this is a tele-echo program that you can learn everything that you ever needed to know and more. And then if anyone is interested, I think this is just really ripe for a medical student or an undergrad really who's passionate about equity work, trying to prevent this in the first place, right? Most of my children with volvulus, their intestinal failure was preventable if maybe we could just collaborate on a code bowel the way the surviving sepsis folks did it in the 90s. So how do I take care of folks with intestinal failure? I'm going to just go through in the next few slides my style and my approach. We could talk more in depth depending on the questions that folks have. This really applies to short bowel syndrome more than congenital enteropathy or pseudoobstruction. The management of pseudoobstruction and congenital enteropathy is a little bit different because their pathophysiology is different. Although I will say that even folks with congenital enteropathy and pseudoobstruction can achieve some amount of meaningful either motility or enteral feeding, but it really depends on their unique genetic and sort of special background. But for children with short bowel syndrome, who make up about 2/3 of most clinics programs, I really believe that if you get the right care with the right team at the right time, we can get most of our kids with NEC-associated short bowel syndrome off parenteral nutrition by age 2 and get them definitely ready by kindergarten. And so these are some of the techniques that I use, and these are my clinical pearls. I don't have multi-center prospective data to back any of this up. This is my style and my approach and what we do in our program. This is sort of based on how I was trained. And I'm hopeful that future prospective studies will help us understand if this approach is good or bad or needs to be adjusted. So I have sort of 6 pearls. The first thing is really trying to achieve meaningful continuity. So if you don't have pseudoobstruction or congenital enteropathy, I really think that doing a takedown earlier rather than later can really speed up rehabilitation and save the liver. There's a lot of reasons for that are sort of out of the realm of this talk, but I'm happy to entertain questions if folks have questions more that are more surgically oriented. Avoiding diarrhea is really the mainstay of intestinal rehab. So this is really true rehab in that you want to effectively push the intestine using food to grow, but you can't push too much or you end up like the 4-year-olds in the case. You remember in that case, the mom was feeding the baby as much as they could because they were so worried about the weight loss. The issue is that kid's intestine had a limited absorptive capacity. And because they didn't have TPN on board, everything that child ate just came out his bottom, and all the fluids and food he was using was just going to replete his losses and not really going towards organ growth. And that's what happens all across the globe, right? This is why diarrhea can be the #1 killer of children internationally. And it's really because the intestine has a limited absorptive capacity. So if you use TPN for the part that the intestine can't handle, and you feed just the amount that the intestine can handle, using those two together, you can get the gut to grow and eventually rehabilitate. It's very plastic. And then that's how I hope to get folks off TPN by kindergarten. Protecting the liver, I think, was the mainstay of our care, or the main focus of our care, especially in the 70s, 80s, and 90s. And so that's still a focus now, although we have newer fat formulations that are less toxic to the liver. And so we're able to maybe shift our focus a bit more towards quality of life, development, and other things rather than just protecting the liver. And then I'm going to skip these 3 for the interest of time, but you have them. And if you have any questions, I'm happy to chat at the end. So what does the data say currently? And I've got a few slides of graphs, and then I would love to open it up for question and answer. We are part of, here at Stanford and many other centers, there's 4 centers on the West Coast, multiple centers throughout the country, and then multiple centers internationally. We are part of the first prospective international multi-center database trial called the International Intestinal Failure Registry. And we're collecting data on our practices, right? You heard me say, this is how I do it. This is how I was trained. That's how we all kind of do it, right? Because the intestinal failure world is really about 60 years old, it really is a bit of an apprenticeship. So I owe everything that I know to my mentors, and they owe their mentors, and that sort of thing. But we want to know, right? Is there a best practice? Is there a way that we can reduce irrational variance and really improve care for our kids? So in blue, you'll see the Stanford site numbers, and in red is the total registry. This registry had a pilot phase. So for anyone interested in doing database research in the future, usually before you can get funding for a large international multi-center study, you have to demonstrate that it has value, usually with a pilot. So Stanford was not part of the pilot phase in 2019 and earlier. And then when I joined in 2019, we got all these patients enrolled. So you could see that in 2019, our enrollment went up. Then the pandemic hit, obviously, and there was a lot of shuffling around. And then the pilot phase study moved towards the prospective. So our first patients, after we got our data transfer agreement, if anyone wants to know what that is, I can talk about that. After we got our IRB approval and all of the grants administration paperwork done, we got our first patients enrolled in 2022, and then we've had a few other patients enrolled in 2023. And you could see that compared to the registry, again, the registry is in red and Stanford is in blue. We have, I would say, a lot of young patients. So infants under the age of 1 are 92% of our patients, and just 8% are older pediatric patients. And you can see here that we don't have 5-year data yet because we're only like at 3 years. So the lightest color is the 1-year data, and then the medium color is the 3-year data. You can see that at 3 years, we have a significant portion of our patients have achieved enteral autonomy. None have required intestinal transplant, none have been listed, and none have been lost to care, or none have died. This is another way of looking at that enteral autonomy number. The Stanford, again, is in blue. The registry here is in red, and then transplantation is in the large, the tiny dash, and mortality is in the large dash. So you could see for the registry as a whole, mortality is quite low, right? Mortality is less so far at 3 years, less than, I would say, 7-8%. And transplantation rates are also quite low. Enteral autonomy here for the registry is already somewhat around 50%. And this is there's sort of a peak here at year 1 and then going to year 3. I would say that probably the main reason that the registry numbers look, quote, lower than Stanford's numbers is because we have not yet in our cohort had any enrollment for children with pseudoobstruction who cannot generally achieve enteral autonomy. All the children that we have enrolled have been infants with short bowel syndrome. And again, our goal is getting them all off by age 2. So we got to that goal. But I think that's probably the difference that you're seeing, and that there's also more patients with congenital enteropathy in the registry than there are at our site. This is our portion of patients in the registry with intestinal failure associated liver disease, vascular thromboses, and line infections. We're doing pretty good there. I will have to get back to you if you guys invite me back to talk about why we have so much oral aversion. My sense is that I entered this data by hand, and I really included anyone who's even getting a little feeding therapy or who's a little bit of a picky eater as having oral aversion. So maybe I need to readjust the quality of my data entry. Either that, or I am giving everyone oral aversion, and we will need to fix that. I don't think that's the case. I'm mostly kidding. So I'm gonna just briefly highlight, and we'll get back to the cases, and I'd love to answer questions, but this is a huge team of people, right? So these are some of my mentors. So this is Dr. Martin. He is an internationally known expert on diarrhea, and I learned everything I know about diarrhea from him. This is Lori Rand. She was one of the first nurse specialists that taught people how to get home with home TPN all through the 80s and the 90s. And I basically learned everything about home care, about what it really means to live with intestinal failure, how to take care of a central line and a G-tube, and so much more from Lori. This is Dr. Dunn, and he is my mentor here at Stanford, and he's also an innovator in the medical device that I mentioned regarding distraction enterogenesis. And Dr. Vargas was the medical director for home TPN at UCLA, and I learned everything I know from him. So you can see there's a lot of apprenticeship. And for whatever field you guys pick, even if it's not intestinal failure, although I really encourage you to join this field, you got to get your team, right? You have to have your mentors, and you have to have your current awesome team. So we have Danielle Leckie as our office assistant, and she really understands our children's and parents' coordination needs. Erin and Andrea are dietitians, and we could not do this job without them. Jason is our social worker. Missy and Anthony, who didn't give me a picture, are fabulous nurses. They make sure our kids don't pass from central line infections, don't lose their access sites because of central line infections, and are really the front line for our patients. Dr. Zhang and Dr. Hurdes are my colleagues in this work, and Dr. Ng and Dr. Rajaram are our pharmacists. And so it's a huge team of people, as you can see, but this is what's required to take care of patients well. So I'm going to get to the post quiz. And I don't know, Michael, if you want to open it up for question and answer now, or if I don't know how your post quiz works. So
Yeah.
What do you think?
Yeah. So how about just to give some time for people to get around to the quiz, let's go through questions, a couple questions first, and maybe around like 15 minutes from now, we can go back on the answers for the post quiz.
Okay, sounds good.
Yeah. So the first one we have is about your choice of gastroenterology as a residency in general. I know that you have the subspecialty pediatric gastroenterology, but before that, with your residency selection, what was it about gastroenterology that attracted you?
Oh, that's a great question. So I will tell you that I was the person that never knew what they wanted to do, but I was always very sort of mission focused, right? I am a daughter of immigrants. My parents really hustled, and I felt like their journey really informed my journey, right? So I felt really strongly that everyone in the United States should have access to quality education and healthcare. And I knew that leaving high school. But when I got to undergrad, I really didn't know what I was going to do. So in undergrad, I ended up deciding on clinical medicine instead of health policy, which is initially what I thought I would do to try to achieve health equity, right? I decided on clinical medicine because the very first patient I ever took care of was a trauma patient at LA County. And that experience really changed my perspective on the role of the clinician and the role of the policymaker. Obviously, I think they're both really important, and I'm still sort of involved in health equity work, but I found that I was drawn to clinical medicine. So that was like decision one, right? Do I do policy work or do I do clinical medicine? So that's how I chose to be a physician. And then getting out of undergrad into medical school, I really just dug deep into every single rotation. So I was never a good test taker. I was never someone who studied for tests because I have a chip on my shoulder about that. And I felt like learning was for me and for no one else, and for my patients eventually when I realized that I wanted to be a physician. And so I learned what I needed to learn in medical school because I wanted to be a good doctor. And so what that sort of style lends yourself to is you have to explore, right? It's not easy when you kind of don't have a set goal in mind to like go get that goal. I was just like, what feels good? That's just how I am, right? I don't do anything unless it feels right. And so I did all the rotations. I loved every single one. I was really drawn to surgery, although when I went to medical school, people were still telling women, especially where I went to medical school on the East Coast. I thought, I heard a lot of, it's not a good field for women is what I was told by several people. And I didn't question it at the time, right? Now I'm like, hey, wait, that's not okay to tell anybody, right? But I didn't understand that when I was 23, 24 years old, right? And so I said, okay, surgery is not for me. I was told it's not for me, it's not for me. Then I found myself attracted to the ICU. I liked taking care of people who were really sick. I liked providing support to their families. And I liked sort of the multi-organ aspect of it. So I thought for a while I was going to be an ICU physician, actually. But then when I was in the ICU throughout my pediatric residency, and I chose pediatrics because I actually applied to med peds and decided that I was more peds med. So that's how I ended up in pediatrics. But when I was in the ICU as a pediatric resident at UCLA, I realized I was actually really more drawn to the GI folks and the GI patients. And I saw myself in like some of these mentors that I had described. And so I actually took 2 years off. I was a general pediatrician in South LA for 2 years. I loved that job. I didn't leave general pediatrics because I hated gen peds. I actually loved the place I worked. I made more money there than I make anywhere else. And it was like a great job, but I really just was drawn to nutrition. And so that's why I chose to do GI fellowship. And now I wouldn't change a thing, right? Like I love taking care of families with intestinal failure. We had a visiting professor from Canada who joined us in clinic, and she made a comment like, wow, your families are amazing. I was like, yeah, they are. Like my patients are amazing. My families are amazing. My team is amazing. And it's just really good work. I think medicine's a hard gig, right? There's a lot of labor, physical and emotional labor that goes into medicine. And so you don't do something that like vibes like that, I don't feel like it's worth it.
100% agree. It was a windy road for sure, but it led to a great career for you. Another question, and this is aside from the specialty, more so about the chart you had. One of the points you raised was that access to treatment on the East Coast is more accessible. So a student is asking, why is it that the West Coast in particular doesn't have that same access?
So I think some of this is actually just geography. The centers of excellence on the East Coast are just located in proximity, right? You've got like 3 in New York, a few in DC, a few in Ohio, a few in Pennsylvania. And so folks can actually drive not a very long distance within that kind of 100-mile radius, right? And have access to really, truly local care. But for example, here on the West Coast, right, getting from like the easternmost border of Nevada out to San Francisco is like 1,000 miles. And so I think part of it is just geography. And then there's probably some policy underpinnings to this, right? In the way that folks are licensed. People are not licensed in multiple states usually. And that applies to all the professionals, the nurses, surgeons, physicians, pharmacists, dietitians, everyone. So it's a really good question. I think some of it is geography, but I do think probably some of it has to do with some underlying policy inequities that I would love to brainstorm with anyone that's interested.
And another thing you mentioned, this was just a term you brought up, You said distraction and neurogenesis.
Yeah,
Can you explain a little more about what that is?
yeah, absolutely. So the mainstay of what we do with traditional rehabilitation is that kind of push and pull I was talking about. And so really the push is feeding, right? And if this gray bar represents what the intestine is capable of absorbing without diarrhea, that's the push, right? And then TPN kind of makes up the rest of it, right? If this is 100% and this baby's intestine was cut short to 70%, it's only going to be able to really absorb 70% of that baby's needs. So that's the traditional sort of push and pull. And in this case, we're using food to increase the absorptive capacity. This includes like physically growing gut, right? So we basically say the food stimulates the crypts. The crypts are where the stem cells live. That increases the villus length. As the villi increase, you have more enterocyte mass, more microvilli, and more villi. And from there, you can absorb food. And over a very slow period of time, for some children, 2 years, for other children, 15 years, you sort of expand the amount of food that the kid can tolerate and reduce the amount of TPN. That kind of makes sense. Distraction enterogenesis is an innovation, and it's currently being studied in clinical trials. And if you want to read about some of the preclinical trial, there's really amazing basic science that was done by Dr. Dunn. If you just Google James Dunn, distraction enterogenesis, you'll find all his papers. Or if you go to his Stanford profile, a lot of them are probably listed in his publications. But in this case, rather than simply using food to push the gut to grow, he uses mechanical force on the intestine, and that stretch is what actually lengthens the bowel. So he's physically stretching the intestine using a little spring, and that spring exerts force on all the layers of the intestine, right? The mucosa, submucosa, the muscularis, and the serosa. But really, it's just in the lumen of the intestine. It's a really light spring, so it doesn't perforate, at least that we think from animal models. And so that's what distraction enterogenesis is. And so what we do is we effectively insert this spring. In the pediatric case, it's not been FDA approved, obviously, so we haven't done any in pediatrics, but in animal models and in adults, the spring has been used, and it stretches and pulls the intestine. So that this speeds up and helps me get to my goal of getting everyone to kindergarten off TPN, right? Instead of just using food to stimulate the crypts and the stem cells, in this case, we're using mechanical force. So that's what distraction enterogenesis is. And I believe Dr. Dunn's background is actually, he is a physician and a surgeon, but he also was a biomedical engineer. So there's tons of opportunity, right, in medicine to bring your interest to the table. And with just good mentorship, persistence, you can really achieve incredible things.
100%. I've seen a lot of great progress made when you cross over engineering and medicine. There's actually, I think, some schools now that are like specialized in engineering. They're engineering-based schools. I think they have one in Illinois, Carl, Illinois. So,
oh, that's cool.
It's good to see. Another question, and this is about your MPH. So, in terms of timeline, did you receive that during medical school, after medical school, before? And what are your thoughts on timeline in terms of receiving an MPH? Do you think that there's somewhat of an optimal time, given the background knowledge that you have with medical school?
Great question. So I might give a little bit of a long-winded answer to this. So I chose to do my MPH in the middle of medical school because I truly was like, I'm going to save the world. I'm going to learn about insurance issues, and I'm going to learn about why there's all these disparities. And I'm going to really do this in the middle of my medical school training because I thought it would inform my decision about subspecialty. I thought it would inform how I could take better care of patients. Many thousands of dollars of debt later and a year and a half. So what I did is I took a year off between my second and third year, which means I didn't get to graduate with my class that I, was really quite attached to. And I took like a summer, that first summer between first and second year I spent on my MPH. I was bi-coastal, so I was like in med school in Pennsylvania, and then I went back to LA because I obviously was really excited about the public health infrastructure in Los Angeles. So yeah, I did that. I don't recommend doing that. In fact, I think if you're really interested in health equity work, I don't think that you necessarily have to have a master's in public health, unless you want to work at the county in a primarily administrative non-clinical role, or you're really interested in something like the epidemiology, the EIS program, like at the CDC, or being part of the State Department or something like that, having sort of a more hybrid, truly policy-focused career. I think if you want to be involved in equity work as a physician, it is everywhere. And I think that's something that wasn't really clear to me, right? When I told you the time that I thought the pivotal experience was working at LA County. And so I thought that in order for me to serve people who are experiencing oppression and to be of service to them, that I had to learn about those systems and be in that space. And that's absolutely not true. Medicine, truly, every single one of us, we are dealing with the downstream effects of systemic racism and oppression and these other systems things. So no matter what field you're in, whether you're a neurosurgeon, whether you're a cardiologist or a GI doctor, you're going to see this. And so knowing what I know now, I feel like I didn't have to go to MPH school. But I think if you are really dedicated and truly interested in that, I would say the time that makes the most sense and is the least stressful to you personally is what works. I think you could do it before medical school. You could do it in the middle. I have colleagues who did it after residency because they just wanted that skill set. It is really fun. I had a blast, but yeah, that's sort of a long-winded question. And I think the finances really matter, right? And that's why I bring up, it costs a lot of money unless you have a scholarship.
Yeah, it really does. There are a couple of programs I know out there during medical school. I think that would supply that kind of aid. Maybe during residency, though, I know there's some programs like that too. Another question, going back to specialties. So you mentioned that intestinal failure is sort of like training in it is sort of like an apprenticeship, just because it's been around for only 60 years. And after going through quite a few sessions now, we kind of see that trend with these newer subspecialties. They become more of an apprenticeship early on, and then later on, they might develop into their own fellowship. Do you think that will happen with intestinal failure? Does it look like it's on track to become its own fellowship, become its own board exam?
That's a great question. I wonder how some of my colleagues nationwide or internationally would feel about that. I would say that if you go back, you think about that graph where people are really stretched thin, right? Like thousands of miles. I will say that at most centers of excellence, there's like one of us, right? I'm very lucky in that I get to work with, James, Yo-Yo, and Rachel. I have a team of physician colleagues, so I'm not alone. But I would say that a lot of centers, the folks who are doing intestinal failure work are alone. And so they just don't have time to make a fellowship program. But I do think it is really subspecialized work, right? I sort of end up acting in a coaching or a guiding role for all my families. And so when I'm in clinic, my head is always kind of in the hospital. When I'm in the hospital, my head is kind of always in clinic, and we're just constantly on. Like I'm on basically all year long. But I think that's because of these inequities, right? I'm not on all year long because we don't have a fellowship program or specialized training. I'm on because there's just so much inequity in that my patients experience. And so it sort of just ends up being that way. But maybe in the next 10, 20 years, things will be different. And yeah, maybe we will have our own board ACGME certified subspecialty one day. I think that would be really cool.
Yeah. Subspecialties really evolve a lot faster than we think. It's crazy how they're evolving. In fact, I think we had a specialty called otology. It was a subspecialty of ENT. I never heard of it before, but they're popping up everywhere. So hopefully we'll see something soon. Another question we had was about your education. So you mentioned you attended medical school in Pennsylvania, then came back to California for residency and fellowship. Did you see any contrasts in the kind of patient populations you dealt with between an area like Pennsylvania versus Los Angeles?
Really great question. So I didn't, and I think this really speaks to, they say like Virchow's quote, right? Physicians are stewards of the poor, or something like that. Everywhere I've gone, I've seen really just heartbreaking consequences of inequity, whether that was in Pennsylvania or here. I think there's definitely diverse populations in all throughout the country. And so, for example, in Pennsylvania, I took care of people who were part of the Mennonite or Amish community. I haven't taken care of any folks from that community out here. Out here, we take care of a lot of folks who are refugees. In Pennsylvania, I never took care of folks from the Hmong community, for example. There are differences in language. I will say that I learned sort of clinic Spanish in LA, and I had a very hard time in Pennsylvania learning it because it was a different accent. There's other like ethnic groups that were part of the Spanish speaking community out there. So there are some differences. I guess what I would say is if you go into medicine, I think you have to understand that you are dealing with downstream effects of inequity, no matter what field you choose, and it has to be part of your job. I would say my training was a little bit different. So I felt like I learned a lot in both places, East Coast and West Coast, but the flavor was a bit different. I felt like I had a lot more service and more opportunities to learn from clinical work on the East Coast. Like as a third-year resident, I held 5 patients on my own. I talked to all the consultants. End of third year, I entered my orders, the resident approved and signed off. But on the West Coast, it's very different. I think there's more opportunities for sort of didactics and more educational time, but maybe some of that clinical time is a little different. Like I've noticed at the 3 different academic institutions that I've worked at, that they don't carry as many patients, right? Medical students carry 1 or 2 patients, if that. They don't enter orders. They're not always calling consultants. Sometimes you can, but I would say that's probably more of like a cultural difference. That's just my opinion. But I thought there was merits to both styles, right? You do have to learn from your patients. You cannot just learn from books, but then you also need the books. You can't just learn from your patients. So that service learning balance is what you want to ask for when you're going on the interview trail and trying to identify a residency program that's going to be a good fit for you. You want to ask every program, like, what is your service learning balance? That's the nice way of asking that question.
That is a question that will come in handy, I'm sure, for a few of us who are going to hopefully be in those interviews maybe a couple of years down the line. So thank you for sharing. One other question I wanted to ask is, you had pediatric gastroenterology as your subspecialty past gastroenterology, but are there any other subspecialties that you could have taken, any other routes that are also a subspecialty at that same level?
Yep. So in both medicine and in pediatrics, there are multiple subspecialties. So medicine and pediatrics are 3 years each, and then all the fellowships are basically another 3 years. So sorry, Michael, just to clarify, are you asking what I personally would have chosen if it wasn't gastroenterology, or
No,
just within?
Just generally.
Oh, okay.
Yeah.
So I think anyone who goes into a medical field, medicine or pediatrics, has those opportunities to subspecialize. So cardiology, endocrinology, adolescent medicine, let's see, who am I missing? Nephrology. I did think I wanted to be a nephrologist for like 2 minutes because when I was at Penn State, actually, the person who got me interested in TPN, his name was Steve Wassner, and he trained with Malcolm Holliday, who was a famous nephrologist, made the 4-2-1 rule. He ran the TPN service for the hospital at the time. At least that's what I think. Maybe that wasn't all of it, but in any case, yeah, so nephrology is really cool. Nephrologists deal with dialysis, for example, and they deal with renal transplant. Rheumatology, also another incredibly underserved field, and both in adult medicine and in pediatrics, incredibly important. Some of my favorite collaborators are rheumatologists taking care of folks with lupus, with other mixed connective tissue disease, lots of different things. And there's a lot of overlap with rheumatology and gastroenterology, actually. So yeah, I think there's so many opportunities to explore what fits, right? You got to find something that fits your personality, right? Like I told you, like I was never someone who was really good at just like sitting down, grinding, like getting the tests, but I could study what really spoke to me. And I think the folks that are the happiest in my experience with the least amount of burnout are folks who really understand the labor that's involved in whatever field they've chosen, but also truly genuinely care about it. I think if you have reasonable expectations about just the labor and really care about the people you're taking care of, then you'll be fine.
All right. And we just have a few minutes left, but one more question I wanted to ask is about telehealth. So how has telehealth progressed in your field? Have you used it a lot lately, especially given that, access is limited?
Absolutely. So for a state like California, which is huge, right? Telehealth is critical. And for a field like mine, where I'm making sometimes twice weekly, daily changes in the outpatient setting, I need telehealth and my patients really deserve it. So we here at Stanford had telehealth actually just like maybe a year before the pandemic, we were ramping it up. And so I had at like 2019, I had, I would say probably 80% in-person clinics and one telehealth clinic per morning. And I loved it. I thought it was a great way to provide counseling, right? Provide result review. So like if I had done an endoscopy, which by the way, anyone who loves procedures, definitely do GI. It's like so fun. But I could do like results sharing. I could talk through the pathology with families. That doesn't really require like an in-person visit, right? And rather than make my family drive 300 miles to say, hey, your pathology says X, Y, and Z, having that conversation by telehealth is great. Certain other diagnoses I felt like really fit well with telehealth. So that was 2019. And then the pandemic hit and it became absolutely necessary to provide ongoing care. And so we did a lot more telehealth. At one point, my clinics, I think my division manager could tell you better, and she'll probably be mad at me if I said it was 70%. It may not have been 70%. It was a lot though, 50% telehealth. Now I think we're really privileged to have an opportunity to use it appropriately, right? So I will tell you, especially in the work that I do, where the physical exam really matters, you could probably tell even from that case of the 4-year-old, right? You probably couldn't see all the stuff I was pointing out. I know it's there because I've seen people in real life with that, but you cannot tell unless somebody is in front of you who they are, what they're about, what is the meaning behind the story, the words that are coming out of their mouth. I can't tell you, being in person is so critically important. And so while telehealth is great because it reduces cost of travel, it improves access, it allows for closer follow-up, and I think it provides a great opportunity for counseling. I think that the in-person exam is so important. I will tell you, I also had this weird observation lately that I've had some families that I've only known in telehealth because I met them in the middle of the pandemic and they just never came to see me in person. Then they finally came to see me in person and it was like I had never met them. It was it's a totally different experience. And as a clinician, the data that you obtain in person matters. I will tell you for the rest of your careers, like if you don't remember anything else I talked about, I will tell you in person really matters. There are kids that I thought were one way, and then I saw them in person, they were completely different. Like it changes everything. And so, yeah, I think it's great for established patients. I try not to do it for new patients, unless it's just like a second opinion and they want to see if it's a good fit before they come see me in person. Yeah, that's my approach to telehealth. And the complicated thing, unless you get licenses in multiple states, you actually cannot provide telehealth outside of the state that you're licensed in. So that can be a big barrier to care.
Yeah, that is a great point. I completely missed on that. Very, very true. It has its pros, has its cons. So has to be used wisely, I guess, in that case. But I don't believe we have many answers yet for the post-quiz questions. Would you mind just going through the explanation for us?
Yeah, absolutely. So the post-quiz, what are the three major causes of intestinal failure? So the three major causes are short bowel syndrome, and that accounts for about 60 to 70% of patients in most intestinal rehab programs. Short bowel syndrome is also an umbrella term. It can include intestines that have been cut short by volvulus, necrotizing enterocolitis, motor vehicle accidents, sometimes fistulas, and some other causes. So I would say that even though it's sort of one diagnosis, it is also an umbrella term. CODES stands for the congenital onset diarrheas and enteropathies. These are those congenital diarrhea disorders. And so CODES is that that case of the mom who's getting the amniotic fluid tap. So in that case, the cause of the high amniotic fluid was actually congenital diarrhea, meaning that the baby was secreting fluid into their lumen prior to even ever having been fed. So that's an example of congenital onset diarrheas and enteropathies. And then pediatric intestinal pseudoobstruction, or chronic intestinal pseudoobstruction, as they say in the adult world, that's the probably the second most common. And that was the case of the girl who had multiple admissions to the hospital for abdominal distension and constipation. The case that I had illustrated there was due to an ACTG2 mutation, where the muscle layer of the intestine and the muscle layer of the bladder does not work properly. So the three major causes, again, short bowel syndrome, congenital enteropathy, and pseudoobstruction. And then to answer the question about if the intestine can grow back, if it's cut short, and what treatment is actually needed to rehabilitate the intestine. So that's parenteral nutrition. And this is the reason why the 4-year-old boy, despite his family giving him all the food that they could, he just couldn't catch up, right? He had short bowel syndrome. His intestines were short. The food he was receiving exceeded his absorptive capacity. So he just had diarrhea, and he didn't have TPN on board. So he couldn't regrow his gut. He couldn't heal it, and he couldn't achieve the caloric intake needed for his growth and development, which is why he developed kwashiorkor. So parenteral nutrition is the treatment for intestinal failure. And with appropriate utilization of the rehab team, nurse-led training to keep the central line clean, and appropriate use of parenteral nutrition, we think now that basically 80% of people with short bowel syndrome specifically can adapt. And this has increased from, like 50% in 1987. But even in 1987, I think this is fascinating, right? 10 years after pediatric patients were going home, half of them came off TPN. And so to me, this is like such a beautiful field, right? That you can really, truly help folks with a disability really achieve lifelong independence from the tool that's needed. And yes, they still have a disability. Yes, they still have to manage, but it becomes more of a chronic illness and they don't need the TPN lifelong. And 90% survive with equitable access to care, right? The paper that had the paper by Manpreet Mundi that had the graph of like how far people are traveling has some other facts that are really just astounding about what happens when you don't have equitable access to care. So I really encourage folks to read that paper if you can. And just to sort of leave you with what can happen when you do have equitable access to care. So this young gentleman had, that scar across his abdomen. And you remember the history of diarrhea. Really, that's not an uncommon story. The photograph is really traumatic, right? It's actually stolen from the Wikipedia page with permission because it's public record of what kwashiorkor is. But I see this all the time. I just saw this like last month and the month before. So this is California in 2023. It is not an uncommon thing, unfortunately, and it has treatment, right? So with access to parenteral nutrition, a rehab team, His growth and development normalized. He entered kindergarten reading, talking, running, playing. His diarrhea slowed, and with careful rehab, he achieved long-term adaptation. So you can take a kid who is very, very sick and really get them into the place that every kid deserves to be, which is where they want to be and where their parents hope they would be.
Well, that is great to hear. I do have some last things to say, but I think that's a great place to end. I really do appreciate you taking the time to answer all those questions. Those are some really, really insightful answers. So it was great to hear, Dr. Shweta. I do have some last reminders, though, before we do close out. So for those who would like to earn credit for their attendance today, we do have a quiz, which is posted in the chat. That quiz, if you do pass it, you'll receive a certificate and we'll send that automatically. It should be sent automatically. And it's, like I said, posted in the chat. It's also on our virtual shouting page. 10 questions. If you have 6 or more correct, then you will pass. And it will be due on Wednesday of next week, June 7th at 11:59 p.m. Central Standard Time as usual. Like I said, after passing, you should receive a certificate sent to your inbox. If you don't receive it in your inbox, please do check your spam folder. But if you find it not going through to either, I should say, then please do email us. Again, our email is community@hearts4health.org. And our next shouting session will be next week on Monday, June 5th, again, at a regular time, 7 p.m. Central, with Dr. Chen. He's a double board certified emergency physician specialized in medical toxicology. I think that will also be our first time seeing a new specialty. So just some last things I also mentioned at the beginning, but I want to mention again. If you want to hear us for more shouting sessions, we do have them posted on our listserv and our Instagram page. Dr. Shweta also mentioned Lift Echo. They have a whole series. If you wouldn't mind pulling up that slide again, if anyone would like to look at the resources over there, it's pretty expansive. And if you wouldn't mind maybe providing some more context, to my understanding, it's a lecture series.
Yeah, correct? Let me actually just go ahead and pull this up because I think Lift Echo and other tele-echo programs like it are extremely important. So Echo was developed in the hepatitis C world. And the idea there, again, is that local care is the best care. Nothing that we do in a fancy academic center is any better than what you do in the community. I know this personally because I was both a community federally qualified healthcare pediatrician, and I am now at a large academic medical center. So ECHO was developed in the Hep C world, and the idea was if you train primary care physicians on how to manage hepatitis C, you can achieve viral suppression and cure. So using that, and so sorry, am I sharing my screen? Can you see it? Okay.
Yeah, we can see it.
Perfect. So this tele-echo program was really designed to help primary care physicians, gastroenterologists, surgeons, transplant physicians, pharmacists, dietitians, nurses, and other folks involved in the care of people living with intestinal failure to just be trained, really. And so it started really with this sort of spoke and hub model. And there's a really nice video here. You can see Dr. Iyer talk about, why they started this. And this is run out of Mount Sinai. You can get CME credit. So once you, do become whatever health major you choose, you'll still need CME. So you can attend, you can get CME credit. And it's for each and every subspecialist of nurses, pharmacists, physicians, dietitians. And then the nice thing, if you guys join, not only can you go ahead and just join the live stream, it's 10 a.m. Pacific Standard Time, 1 p.m. Eastern Time. People join from all over the world, the entire globe. It's so fun to see colleagues from New Zealand and South America and really just all over the place. But they, you can see all these different topics, but then they also post, and I'm trying to find where they post the didactics. So if you ever want to go, oh, here we go, didactics archive, you can go back and watch the full didactic. So what is not recorded is the first 30 minutes, which is a clinical case. And that's just to, protect patient privacy and to make sure that people can discuss things that may or may not be controversial in a safe manner. But the didactic is always recorded. And so you can go through all these different topics and learn about every aspect of intestinal failure care. And it's meant to be for a broad audience. So don't feel intimidated like at all. We're all really nice in the intestinal failure world. Like you'll make new friends and it's a great opportunity to learn. And if you are interested in like joining intestinal failure as a career, please reach out to me. I would love to provide any mentorship that I can. Because again, I think the more of us that do this work, the less distance my patients have to travel.
Yeah, it is really true. We see it by the statistics. And we do really appreciate you for sharing all that, for offering your help too. I really do recommend Lift Echo, y'all. And like Dr. Shweta said, it's for a broad audience, so don't feel intimidated at all. But that is all. I really do want to thank you. Let's hear some thank yous in the chat for Dr. Shweta. She took some time to get this presentation together. And I mean, your enthusiasm shows through for this specialty. It really does. The whole presentation, we could all see it. So it's really admirable to see. So I really do appreciate it. I can say the same on the behalf of other students too. But yeah, thank you so much for speaking to